So I'll be talking today on complications of hemodialysis. So I am sure this complication would have been encountered by everyone who is doing a hemodialysis procedure. So without wasting much time, I would like to go into the complications of hemodialysis. So the complications of hemodialysis can be broadly classified into acute complications and late or chronic complications. So this is how you look at the complications of hemodialysis. Now I would be focused only on the acute complications of hemodialysis. So acute complications of hemodialysis can affect any of the systems of the body. Like you can have cardiovascular complications, which include hypertension, arrhythmia, sudden cardiac death, and Steele syndrome. Neuromuscular complications include muscle cramps, restless leg syndrome, dialysis disequilibrium syndrome, seizures, and headache. Hematological complications include complement activation, hemolysis, and hemorrhage. Pulmonary complications include dialysis-associated hypoxemia. And of course, there are a lot of dialysis reactions like anaphylactic reactions, first-use reaction, reuse reactions, and kinase-mediated reactions. Then often there are technical complications which include air embolism, incorrect dialysate composition, hypo or hypernatremia, metabolic acidosis, metabolic alkalosis, and blood loss. And there are miscellaneous lot of other complications like post-dialysis syndrome, pruritus, and so on. So these are the, in broad, the acute complications of hemodialysis. Now coming to each one of these complications in detail, first we look at the cardiovascular complication. So hypotension is the most important cardiovascular complication of hemodialysis, and this is in fact the most common complication of hemodialysis. And there are a variety of causes of hypotension during dialysis, but the most common cause is excessive fluid removal. Like when you remove excess fluid from the patient, like when the ultrafiltration rate often exceeds something like 0.35 ml per minute per kilogram, or whenever there is a reduction in the plasma volume by more than 20%, what happens is that the ultrafiltration rate will be more than the plasma refilling rate. So that will lead to decreased intravascular volume, decreased cardiac output, and hypotension. So you have to imagine that there is constant removal of fluid from the blood compartment of the patient into the dialysate. So that is essentially what is ultrafiltration. So this the the loss of fluid from the vascular compartment should be replenished by the movement of water from the interstitial compartment into the vascular compartment. However, when the rate of ultrafiltration is more than the plasma refilling rate, there will be decrease in the vascular volume, intravascular volume, that will lead to decreased vascular tone, that will lead to decreased cardiac output and leads to hypotension. Now, this is not the sole factor for hypertension. So you have to be focused on other factors also. Like there could be dialysis related factors, patient related factors, cardiac factors, and uncommon causes. Like this cartoon will illustrate what are the other causes. Like patient related causes include, there could be the patients can have autonomic neuropathy, especially diabetic patients, and their vascular sympathetic tone might not be sufficient to support a vascular tone, so they can develop hypotension. Antihypertensives, use of antihypertensives, medicines, food ingestion, tissue ischemia, sepsis, anemia, acetate dialysis. Nowadays, this incidence is not commonly seen because most of the patients are on bicarbonate dialysis, and increased core body temperature, example a patient with sepsis. Then cardiac factors include myocardial infarction, structural heart disease, arrhythmia, and pericardial tamponade. The last cause always have to be kept in mind, where the patient presents with sudden onset of dyspnea, and often you will have not much of fluid overload, but a raised jugular venous pressure, and the patient will be having a tamponade. This is often an acute medical emergency and has to be identified and managed on an emergency basis. Then dialysis related causes include acetate dialysis, low dialysate sodium, complement activation, and cytokine generation. So all these are factors which leads to hypotension. Then you have to be aware of certain uncommon causes like dialysis reaction, air embolism, hemolytic reactions, and hemorrhage. So this is in fact the almost all the causes of hypotension that can happen in a patient who is on hemodialysis. Then the clinical features are not much. The patient will often complain of nausea, lightheadedness, and muscle cramps. And often you have to anticipate this occurrence of hypotension, and you have to uh, implement some preventive measures. And the preventive measures include careful assessment of the dry weight. Dry weight can be assessed by clinical bioimpedance techniques, IVC sonography, and sometimes by serum ANP levels. But the usual thing that we do is a clinical assessment of dry weight. And you have to minimize intradialytic weight gain to less than 1 kilogram per day. That would be the ideal one. You have to use machines with the use of ultrafiltration controller. Nowadays, most of the machines are volumetric machines. In our days, there were non-volumetric machines, and you had to set the ultrafiltration volume removal on these machines, and this uh, often led to profound hypotension. Then sodium modeling during the hemodialysis, you have to correct anemia. You have to withhold antihypertensive drugs before you start the patient on dialysis. Bicarbonate dialysis is preferred. Then you can decrease the dialysate temperature to 35 to 35 degrees centigrade. So when you decrease the dialysate temperature is passed on to the intravascular blood, and the core temperature of the body decreases, and as a result, there will be peripheral vasoconstriction. So this is how a dialysate temperature, when you lower the dialysate temperature, it prevents hypotension. Then you can increase the dialysate sodium to 140 to 145 millicalins per liter. And there are drugs like midodrine, alpha agonist, which is used around 10 milligram oral, around half to 2 hours before dialysis. So these are in general, the preventive measures to prevent hypertension. So once the patient develops hypertension, you have to put the patient on a Trendelenburg position, that is with the foot end up and the head end down. You can use a 0.9% saline, a 100 ml bolus, and you have to decrease ultrafiltration rate to 0. And if there are muscle cramps, you have to use a hypertonic saline. So these are the broad causes of hypertension, preventive measures of hypertension, and how do you treat hypertension. Then cardiac arrhythmias. Cardiac arrhythmias, there are certain risk factors like left ventricular hypertrophy, chamber enlargement, valve abnormalities, ischemic heart disease, electrolyte imbalance like any disturbance with potassium, calcium, and magnesium, especially magnesium. And it causes around 60% of sudden cardiac death. And acute arrhythmia, you have to terminate hemodialysis and follow the American Advanced Cardiac Life Support Guidelines. And the most common arrhythmia seen in hemodialysis patient is often atrial fibrillation. And the usual underlying cause will be a coronary artery disease. So this is in general the management of cardiac arrhythmias. Then sudden cardiac death, very catastrophic event, but it do happens in patients on hemodialysis, and most commonly seen in elderly diabetic patients. And for some reasons, it is more common in patients with central venous catheters. And the most common cause is a ventricular fibrillation. And management, if technical complications are anticipated, do not return blood. If not, you have to return blood. You have to preserve the dialysis and blood lines for analysis of any electrolyte disturbance. And probably if there are problems with the machines, you have to replace the dialysis machine and run a thorough check of the dialysis machine and the dialysate. Then another complication is a dialysis-associated steal syndrome. And it happens in 6% of arteriovenous fistulas and 1% of arteriovenous grafts. The main cause is a retrograde arterial inflow from the ulnar artery or the palmar arch. So when you start the dialysis, the dialysate machine will the pump, when the pump speed exceeds something like 250 or 300, it will steal blood from the fistula more than the fistula can deliver it into the distal part of the limbs. So what happens is that the clinical features include pale or a blue hand, pain during hemodialysis. Some patients can develop vascular ulcers, necrosis, and can lead to gangrene of the hand. And evaluation is by Doppler or by doing a fistulography or an angiography. Treatment is by ligation of the venous outflow of the arteriovenous fistula. Then a procedure known as drill procedure is used, which is known as a distal revascularization and interval ligation. So this is a treatment for dialysis-associated steal syndrome. Then we'll come to the neuromuscular complications. One of the most common complications that is encountered is muscle cramps. Around 5 to 20% of the patients during the late part of the hemodialysis will develop muscle cramps, often necessitating the stoppage of dialysis, and most commonly involves the legs. And the causes include dialysis-induced volume contraction, hypoosmolality, hypomagnesemia, and maybe carnitine deficiency. And electromyogram will show increased tonic muscle electrical activity. And how do you treat this? By increased osmolality, you can give 50% extra solution, or a IV hypertonic saline or mannitol can be given. And prevention is you have to optimize the dry weight. You can use quinine sulfate, oxazepam 2 hours prior to the dialysis. Sodium modeling will be helpful, and uh, to a certain degree, carnitine supplementation is tried. So this is regarding muscle cramps. Then another complication that is encountered is a restless leg syndrome. Most often, even though it is listed under a complication of hemodialysis, it is usually a symptom which develops in stage 4 or stage 5 chronic kidney disease. It is described by the patient as a crawling sensation in the legs during inactivity or sleep, and is relieved only by moving the legs, and delays onset of sleep, which ultimately leads to insomnia. If you want specifically to do a diagnostic study, you have to do a polysomnography, which combines EEG, electroencephalography, and EMG. And other causes also has to be ruled out, like iron deficiency anemia, hyperphosphatemia, vascular insufficiency, and adequacy of dialysis also has to be checked. And one differential diagnosis is a peripheral neuropathy. Then treatment, opiates are effective. You can use L-dopa or carbamazepine. This is also a problem, especially in, this is described as a problem primarily in home hemodialysis patients, where the dialysis is often done during the night time. Then another main complication is seizures. So the causes of seizures are again multifactorial. You can have metabolic causes, dialysis-related causes, and toxins, which can lead to seizures. Metabolic causes include hypocalcemia, hypomagnesemia, hypoglycemia, acidosis, hyponatremia, and hypernatremia. So all these metabolic causes have to be kept in mind when you are dealing with a patient with seizure. And dialysis-related causes include uremic encephalopathy, dialysis dysequilibrium syndrome, hypertensive encephalopathy, intracranial hemorrhage, atherombolism, and dialytic removal of anticonvulsants. Then toxins. Toxins include a patient who is on alcohol and suddenly is withdrawn from alcohol, aluminum toxicity, and drugs like penicillin. But when a patient in dialysis unit throws up a seizure, the first thing that as a dialysis technician or a person caring for the dialysis patient should do is to check the pulse of the patient. Sometimes it may be a manifestation of a cardiac arrest, which lead to hypoxic encephalopathy and seizure. So check the pulse of the patient and make sure that the patient is not in cardiac arrest. Then you have to evaluate all the causes of seizures as depending upon the etiology. And the treatment there are some the reports which have shown that there is an increased incidence of seizures in children with renal failure. You have to stop the hemodialysis, maintain the airway patency, and you have to send the blood for all glucose and electrolytes. And you have to treat the patient by giving intravenous diazepam or phenytoin. Then another complication that develops is what is known as a dialysis disequilibrium syndrome. So this usually happens in the initial dialysis, but it is also described in later part of dialysis. It happens whenever there is a rapid correction of advanced uremia, like it can lead to neurological dysfunction, and it can also occur with peritoneal dialysis. The clinical features include restlessness, headache, nausea, vomiting, confusion, and seizures. So the main pathogenesis is the cause of this problem is cerebral edema. So whenever there is a patient who is having a blood urea, some very high blood urea level, say for example 300 milligram. So because of homeostasis, the urea level in the blood will be equal to that of the urea level in the brain. That is say around 300 milligram per deciliter. So when you start the patient on dialysis, and if you are doing an aggressive dialysis on the first instance itself, what happens is that there will be rapid removal of urea from the blood. So, but the blood-brain barrier is not so permeable to urea and to accommodate for the rapid shift of the urea. So the urea level in the brain will be very high. So it acts as an osmotic agent and it draws water into the brain. So it will cause cerebral edema. So, and another reason that has been proposed is a paradoxical CSF acidosis and intracerebral accumulation of idiogenic osmoles. And the risk factors include young age, severe renal failure, low dialysis sodium, and a pre-existing neurological disease, and if you are using a high flux dialysis. So the diagnosis is often clinical and it's usually self-limited. If the patient is having a headache, it's usually self-limited, but it can lead to other extreme manifestations like seizures. So there are preventive measures like you have to use a low blood flow rate, you have to use a co-current dialysate flow, you have to use a low flux dialyzer, then bicarbonate dialysis, and you have to use a volumetric machine. And there is no role for prophylactic anticonvulsants or mannitol. It's often a preventive measure. So you have to decrease. You shouldn't do an aggressive dialysis in the first instance, where a patient presents with a severe renal failure. Headache. Now headache is a common symptom, and it's usually bifrontal discomfort and often associated with the nausea and vomiting. And it is aggravated by supine position. Usually, there will be no visual disturbance. These are indicators that you are not dealing with something sinister. And causes include subtle manifestation of DDS, and it is often seen when you're using acetate as a dialysate. Now, coming to hematological complications. One hematological complications that is described is dialysis-associated neutropenia or complement activation. So whenever you are using an unsubstituted cellulose membrane, the hydroxyl group activates the complement cascade in the blood, and it can lead to migration of the neutrophils in the lung, so leading to a mild neutropenia in the peripheral blood. But however, the neutrophils return to the systemic circulation after 6 hours. However, with the current dialyzer membranes like synthetic membranes, they do not activate the complement. So what is the clinical significance is that it might have play a role in intradialytic symptoms like hypotension, chest pain, and nausea, renal injury, pulmonary hypoxemia, and chronic immune system injury. So unsubstituted cellulose membranes are no longer used, but this is a potential complication that had been described with their use. Then this is one of the catastrophic complication of hemodialysis, which is hemolysis. Hemolysis can be intra or extravascular, and it can lead to anemia in dialysis patients. And causes is related to the dialysis procedure, dialysis solution like contaminants like chloramine, zinc, copper nitrate or nitrite, reuse formaldehyde when you're using formaldehyde and the formaldehyde is not properly washed off, and whenever the tubings are kinked. Other causes include insufficient dialysis, hypersplenism, drugs, quinine, and hypophosphatemia. These also can lead to hemolysis, which can manifest itself in the dialysis patients. Diagnosis is often the patient will complain of nausea, vomiting, hypotension, cyanosis, and the tubings will show a characteristic translucent hemolysis blood. You have to terminate the hemodialysis, and it's a medical emergency. It can lead to hyperkalemia and cardiac arrest. And you have to support the patient with circulatory support. Don't return the blood, and you have to discard the tubings, everything, and you have to analyze what is the cause of hemolysis. Hemorrhage. Hemorrhage is usually due to heparin overdose, and these CKD patients are prone to bleeding at specific sites like gastrointestinal AV malformations. Like the patients with CKD are more prone for developing angiodysplasia, especially of the small intestine and the colon. So it can lead to bleeding from these sites. Subdural hematoma, pericardial bleed, pleural bleed, retroperitoneal bleed, and ocular chamber into the anterior chamber of the eye. These are specific bleeding sites in CKD patients. So the causes include a decreased platelet aggregation, decreased platelet granular adenosine phosphate, decreased serotonin level, decreased thromboxane production, and increased endothelial nitric oxide production. So these in general are the causes which are seen in CKD, and this is often complemented by a heparin overdose. Then bleeding time will be the best indicator for a bleeding tendency. You have to estimate the severity of the bleeding loss, hemodynamic stabilization. You have to transfuse blood products, identify the bleeding source, treat platelet dysfunction by intensifying dialysis, modify dialysis heparinization. And desmopressin has been used to contain the bleeding. Then coming to the pulmonary complications, hypoxemia. Arterial PaO2 can decrease by 5 to 20 millimeters of mercury during hemodialysis, and it often peaks at 1 hour. It is thought primarily due to mild complement activation, but usually it is of no clinical significance to the patients unless there is a severe pre-existing lung disease. So this is regarding hypoxemia, and you have to it can lead to hypoventilation by a lot of mechanisms, and ultimately it will suppress the ventilation. There will be complement activation. The treatment is intradialytic oxygen supplementation. You have to use bicarbonate dialysis and biocompatible membranes. So this is how you treat hypoxemia, and it is most often seen with acetate dialysis. Now coming to technical complications, air embolism. This is again a very dramatic acute complication of hemodialysis. It is due to the presence of the air in the circulatory system. And the most common site of air entry is a pre-pump segment. In the pre-pump segment, there'll be negative pressure in the blood circuit, and often there is a high blood flow rate. Usual cause is an empty bottle which is connected to the negative pressure of the blood circuit, negative pre-pump segment. And the clinical features depends upon the volume of the air that is introduced, site of introduction, speed at which the air enters the blood, and the position of the patient. And if the patient is in a sitting position getting dialyzed by chair, the air bypasses the heart, it goes into the cerebral venous sinuses and thrombosis, and it can lead to seizures and coma. And in the supine position, the air gets trapped in the right ventricle. There will be foaming of blood, decreased cardiac output, and hypotension, and ultimately it can lead to cardiac arrest. And you can see foam actually will be seen in the venous blood lines. How do you treat is by clamp the venous line, stop the blood pump. Patient should be placed in the left Trendelenburg position. Then cardiorespiratory support like high flow oxygen, intubation, and mechanical ventilation. And in desperate measures include like you have to aspirate air from the right ventricle, and you can also try hyperbaric oxygen. But the prompt recognition of this complication is mandatory. So don't let empty blood bottles hanging by the side of the patient connected to the pre-pump segment. Then these are electrolyte disturbances like hypernatremia. The causes include altered mixing ratio or improper working of the alarms and monitors, hyperosmolality like interstitial fluid depletion, thirst, headache, nausea, vomiting, and seizures. Treatment is used to stop the dialysis, send bloods for investigations, 5% dextrose. Then you have to do a dialysis with a different machine, and dialysate sodium should be lower than that of the plasma level of the sodium. So you have to adjust the dialysate sodium level. Hyponatremia again is due to defective proportioning system or empty concentrate container. It can lead to hypoosmolality characterized by hemolysis, chest pain, headache, nausea, vomiting, and seizures. Treatment is used to clamp the venous line, discard the blood in the circuit. You should use high flow oxygen and cardiac monitoring. And restart dialysis using a new dialysate. Use high ultrafiltration rate to remove the excess water. And you have to use low potassium in the dialysate, because a low potassium high potassium also can contribute to this condition. Then metabolic acidosis. Causes include defective proportioning system, defective pH monitors, diabetic ketoacidosis, and lactic acidosis. And the clinical features include acute onset of hyperventilation during dialysis. Often it is due to a underlying problem rather than a defective proportioning system. But however, you have to think about a defective proportioning system also in this cause of metabolic acidosis. Metabolic alkalosis is often due to the systemic condition of the patient, like the patient has got a vomiting or a continuous nasogastric aspiration. Then dialyzer reactions. It is a broad group of events that include both anaphylactic as less well-defined adverse reactions of unknown origin. And there are two types. One is a type A reaction and the other is a type B reaction. So type A reaction is similar to anaphylactic reaction. The patient will present with dyspnea, pruritus, urticaria, cough, wheeze, watery eyes, cramps, and diarrhea. And the most important thing is that you should recognize it because it happens within a few minutes of starting dialysis. And the cause is due to it's a immune mediated one, and it is due to IgE antibody to ethylene oxide, and this is known as the first use reaction. And there are membranes with the AM69, and when these membranes are used with the ACE inhibitors, this actually flares up. And other causes include contaminated dialysis solutions. Yeah, the treatment is you have to support with cardiac support, airway, breathing, cardiorespiratory support, stop hemodialysis, clamp dialysis lines, discard dialyzer, and the blood tubings. Then the type B reactions include less severe reactions. Often they present with subtle manifestations like back pain and chest pain. Cause is not clear. It is probably thought to be due to complement activation or a subclinical hemolysis, and the treatment is supportive. So I have discussed almost all the complications of hemodialysis. The vascular complications are entirely different, like the complications associated with arteriovenous fistulas and arteriovenous accesses. These are a separate entity by itself. So these are broadly classified into access-related complications. So I have not dealt into it. So these are, in general, a bird's eye view of acute complications of hemodialysis. So thank you for the patient listening.